I actually think we're in a bit of a lull for having therapies that I am enormously excited about, and that's an honest answer. I think we're, and maybe it's because the development of the checkpoint inhibitors has just been so extraordinarily revolutionary. I think we are now in an era where we've got a lot of we're trying to figure out resistance. And PD-1, specifically PD-1 resistance. We have a lot of clinical trials opening for patients that are resistant to checkpoint inhibition. But I don't know that we have the right strategy to do that as of yet. I think it's watching some of these injectable agents is interesting, but I think we've really got to pay attention to the endpoints that we're choosing as we write those trials. Otherwise, we could wind up in a place where we've got a lot of very promising phase 1 agents that look good in small studies, but then we get to a larger study and that benefit doesn't pan out. So I think we have to be very smart about selecting which strategies we move forward. I think we have to be very rigorous in how we design how to test those strategies. And I think we have to be true to ourselves with the patients we select. It has always been a challenge to enroll patients in clinical trials that are representative of the patients that will be treated ultimately in the real world. And there's a number of reasons for that. Safety being first and foremost. Nonetheless, as you get more comfortable with new agents, it's time to be more inclusive with the population that you treat. And so that's something I think that we're going to need to do as we move new agents into development. So I will say that I feel that payer coverage for patients where the label may not be 100% approved has actually been more generous than what I've seen in the past. And I believe that is somewhat encouraging. There's nothing worse than having a drug that is going to be approved any minute that could really make a difference in a patient's life and not be able to get that drug to the patient because the paperwork just isn't done yet, right? And we were in that situation, with pembrolizumab. I can remember we did what's called an expanded access protocol, which is a protocol that's often available for patients before the drug actually gets to approval, and even in the window before that expanded access opened, seeing patients that really could have benefited that. So I believe that is by and large an improvement. But it also means that when it's too frequently available off-label, it means that patients aren't enrolled to trials and then we don't get rigorous data. So it's there's a sweet spot in there, I think, where we need to hit. But so I do think it's been, fairly generous. However, I still say that it's very difficult to give patients financial advice about treatment because there's no way to be able to tell somebody, what their cost of care is going to be up front. A lot of it is very vague. And that is very, very challenging to people who, are just trying to hold it all together. I mean, when you think about how life-changing a diagnosis of cancer is and how it is, just so stressful just to be able to maintain any sense of normalcy. People want to work. They want to be able to do things and maintain a normal life. And yet a lot of times the financial piece is just as devastating as the clinical piece of this.